Mesdames, Messieurs, merci, bonsoir. Mesdames modératrices, merci beaucoup pour la présentation. Unfortunately, my French stops here. So I'm sorry. I'm very sorry for you, but you have to listen my presentation in English. And I would like to thank Professor Fuad for his warm and kind invitation. Thank you so much. This is the first time I've been in Morocco, and I think that our countries and our people are very similar because we are both friendly into the approach to each other. We are funny. We are very good people together. We can start a very good cooperation as in our mind of Fuad and mine will be next for the next year, the possibility to start with a common project about the training of the operator on thermal ablation, because you have seen in the previous presentation that one of the most critical issues of this topic is to find a very good operator, a skilled operator, because we saw with the excellent presentation of Giovanni Antonelli, excellent because it's one of my colleagues in my division, that the international guidelines now recommend very clearly and state what will be the indication. So I will not repeat what Giovanni says before, but I want to focus your attention on this topic. To let a treatment will be effective and successful, we need 2 or 3 things. The good indication. So the right choice is the best that you can do for the patient. Patient is in the center, is in the middle of the framework of the decision-making for the thermal ablation procedure. You have to accompany him with your hand to the best decision, but it's the patient that should decide. And yes, the choices. Regarding the microcarcinoma, the choice is active surveillance, surgery, thermal ablation, according to the ATA International Guidelines 2025. Nowadays, why you should choose active surveillance? We participated with the Pascal Institution, is one of the most important oncological institutions in Italy, to a clinical trial offering the patient in our hospital the active surveillance as a choice. No one of them accepted to receive active surveillance because they asked me, Professor, why I should observe my carcinoma, because it's a carcinoma, let grow them and growing it and wait for metastasis and so on. Please treat, don't remove, because I want to save my thyroid, but treat by thermal ablation and then we will surveil the nodule. I cannot give a different reply to this patient, ask me for this. So I think that nowadays what the patient will decide is the most important thing. Second thing about the decision making is to choose the best nodule. Unfortunately, not all the nodules are best candidates for the thermal ablation procedure, because or they are greater than 1.2 centimeter, or they are very close to the capsule, or very close to the trachea, very deep near the esophagus, and so on. But if you choose the best candidate, the treatment will be successful and the result will be really impressive, because you will never see the area of the treatment when you choose the best candidate of nodule. Some words about the cytology specimen evaluation, because as you know about the indeterminate nodules, the American Thyroid Association indication are quite not so definitive. Maybe that in a future we can use more complete full panel for genetical test. But nowadays, we can propose the thermal ablation procedure for indeterminate nodules, that means Bethesda 3, okay, when the genetical test is wild type. That means no mutation in the genetical test. In this case, you can propose according to the international guidelines, but this is still controversial. The third basic important consideration is to find the good operator. So find a good indication, find the good nodule, find the good operator. And this is a very important issue because we see that I very often have a lot of people around the world to do training, and I see how many mistakes in the technique are applied by so many operators. So it's important to understand how to move. And this morning, together with me, Fuad decided to do this interesting workshop. I say interesting because the feedback was very good, I think, Fuad, or not. And I think that understand how to introduce the needle, how to move the needle using a platform and not the patient for the first time is very important, because you are more confident, you feel more safe, okay, and you can act in a very proper way, in a safer way. And another topic to conclude this introductory slide is that the patient must be aware about everything. You have to talk with the patient, explain, this is an option, but you can decide at the end of this discussion, okay, professor, I want to be operated, remove my thyroid because I don't want to be treated by thermal ablation. It's okay, because it's the patient that will decide at the end of the process. So the written informed consent, if you go on PubMed, you will find the informed consent of all the major scientific society that recommend and support this document for the treatment of the nodule by thermal ablation. Well, I decided not to present you a classic presentation on the treatment of the microcarcinoma, but I think that better than the words, the images will explain better how to perform a well-done thermal ablation of a microcarcinoma. So about the indication, we were able to find finally a very good candidate, a nodule that was about 1.09, so a little bit more than 1 centimeter, that was not so close to the capsule, at least 1-2 millimeter were defined all around the nodule. It was, according to the EUTIRADS concept, that was an EUTIRADS 5, because it's hypoechogenic, round shape, irregular margins, foci puntati echogeny, because nowadays, according to the ATA guidelines, never say microcalcification, because the hyperechogenic puntati focis not always are microcalcification, but could be also dense colloidal content. So name them foci puntati iperecogeni in Italian, or hyperechoic punctate foci. So this is a best candidate for this reason. It's not so close to the trachea, fortunately, so we consider for the treatment, you see the vascularity, Usually, as you well know, the microcarcinoma are not so well vascularized. So you could think that because some people is convinced that the vascularity of a tumor is hypervascular. It's not true, absolutely, because most of the tumors are not so well vascularized. Like in this case, we have just one spot entering the nodule. You see all the main features, and also at the elastostrain, we can appreciate that the tissue is very stiff, it's very hard, as typical in the microcarcinoma. But these two techniques are ancillary techniques, not mandatory to do diagnosis with these two, because the diagnosis is made by B-mode ultrasound. And again, about the vascularity, we have nowadays, with the top-level ultrasound machines, the possibility to use some microvascular software that are very useful in order to establish the vascularity of the tissue immediately before and immediately after the procedure, in order to understand how much necrosis you have created after the procedure. Now we will start with define and show you the correct technique, starting with the hydrodissection. We have two types of hydrodissection. The first one is superficial hydrodissection. That means that I will anesthetize, okay, the superficial capsule of the thyroid gland. That is the one that includes sensitive fibers, nervous fiber, so that it's unuseful to anesthetize the internal part of the thyroid or the muscle. So you have to introduce the tip of the needle exactly on the white hyperechoic line. When you see that this anatomical virtual space will full open, you can inject very quickly the content of the syringe. See here, not in the muscle, okay? Okay, I found the right space and I continue to inject. By this way, you see, I create a fluid collection. In other words, I transform a virtual anatomical space in a real anatomical fluid collection that I create by injecting with a syringe of 20 milliliter, 10 milliliter of lidocaine, the anesthetic, lidocaine 2% plus 10 milliliter of mannitol. Why mannitol? Because in Italy, dextrose 5 is not sold. I don't know why, but it's not sold. So I was wondering to find something that could be so useful and effective like dextrose. The only one that could respond better than the dextrose is the mannitol, because it's more dense. And if you inject with the lidocaine, it will stay longer on the surface of the capsule. That means with a single injection of a 20 cc of syringe with lidocaine that was diluted, so you reduce the toxicity of the lidocaine, I can perform the anesthesia that will last all the treatment. It's good for 15, 20 minutes of the procedure. Something about the hydrodissection, we have to be very careful about the anatomy. So before starting, you have to understand all the structure where they are positioned. This is the carotid artery, for example. This is the jugular vein, and this is the vagus nerve. So by this way, we are very safe because the injection of lidocaine is very far from the vagus nerve, and we cannot create an impairment of the nerve due to the local anesthesia of the vagus nerve. Then we will proceed, as you can see here, to the deep hydrodissection. Deep hydrodissection uses mannitol alone, no anesthesia, because in the deep area of the neck, we have the phrenic nerve, the cervical brachial plexus. Laterally, we have the middle sympathetic ganglion that can cause the Horner syndrome, for example. So you must be very careful. In this case, we cross the thyroid gland until we can see the tip on the deep space of the capsule, and then we inject with the same technique when we are sure that we are in the right place. Inject what? Inject mannitol. Then we create, as you see there, as the nodule could float in the fluid. This is the best hydrodissection because you fully insulate the nodule from the tissue around, and you can perform a very safe procedure. As you can see, the nodule and the lobe, the right lobe, were completely insulated. Then we introduce the antenna, because this treatment was done with microwave canyon 18 gauge antenna. We are very close to the capsule in the deeper part. As you see, I move with a maneuver that is tilting up. I tilt up, so I let the nodule come very superficial in this case, and I apply the stationary technique in this case. So I don't apply moving shot, but I stay according to the protocol that the company will give us to understand how many seconds I have to stay there before moving the nodule, and the volume that I create during the procedure, I can move to a different untreated area, more superficial or more superior or more inferior. It depends where we are at this moment. It's important, as you have seen, that we introduce the tip in the deeper part, because the hyperechogenicity that we will create during the procedure, that is due to the vaporization of the tissue, creating microbubbles of water going all around through the microvessels. If you start very deeply before, you don't have any problem. But if you start very superficial, the hyperechogenicity, due to the high impedance that the microbubble water have, you will see nothing below. So you have to start always from the deep and then go up. Now you will see we have almost completed the procedure. You can see, watch the tip always. During the procedure, you should be in every moment aware where is the tip of your needle, because I use this technique with microwave canyon because it's, in my mind, safe and very fast. And the necrosis is complete because it's not sensitive to the impedance. You know that by radiofrequency, to obtain an effective area of necrosis, you have to reach an impedance that is more than 170, 180, 200 ohms to be sure that you have necrotized everything. I have seen many operators that when the impedance reach 100, they stop. 100 doesn't mean complete necrosis. So we cannot depend from the impedance only. We have to be sure that when we treat microcarcinoma, by microwave, I am safe because the necrotic effect is immediate. When I turn on the generator, when I push on the pedal, immediately I have the necrosis. Because there is a precise algorithm that will say that in 5 seconds, I have a necrosis of 3 per 3 millimeter, for example. Now I will evaluate the total amount of the necrosis, scanning the nodule vertically and horizontally in order to better appreciate the margin. Then I start evaluating the color Doppler and power Doppler vascularity. You see that still remain vascular evidence in the most superficial part of the normal tissue, not into the nodule. And also you see that the volume of the treated area is greater than the nodule that I treated, because for oncological reason, we need to be more aggressive and also treat at least 2 millimeters all around. The same consideration that we apply for the treatment of the liver tumors. We have to treat the satellite nodules. In this case, for oncological problem, we must save and treat also around the nodule. Then I wait some seconds, minutes, to understand by the software if the treatment is complete, okay? And then I discharge the patient. So at the end of this video communication, it's important to understand what will be the perspective according to the international guidelines. Now they recommend the use of thermal ablation for this treatment. And even if thermal ablation is still considered investigational, it's, in my mind, very promising if we correctly apply the technology that we have at our disposition. Obviously, we require further validation, very big number, because consider that all most of the papers that were written about thermal ablation are on radiofrequency, but from this side of the world. But if you go to the other side of the world, mainly in China, microwave is the technique that is most performed into that world. So I consider that in Europe we should be very careful and sensitive in the use of the appropriate technology. There are a lot of manufacturer companies producing generator and device that are very fragile, or, and this is for me a criminal way to approach to the problem, that recommend to re-sterilize the device many times for different patients, because the cost doesn't allow many people to be treated by this way. I don't recommend. For me, it's criminal, because one patient, one needle, absolutely. And this is important, because technology, manufacturing, company, industry should, as some word from Professor Fuad this morning, industries and us could run in a parallel way. So about the takeaway, I think that it's important to consider the first words that I told you before, the correct indication, the patient must be aware, the correct doctor that should perform. And what about the savior thyroid philosophy? Why we should choose the thermal ablation? Because the improvement in the quality of life of the patient, because there is no surgery, no general anesthesia, no scar in the neck, absolutely, and no long life treatment with levothyroxine. That is important because so many patients refer that their life will change after the medication. Okay? So I think that is important also from the psychological point of view, that the patient can solve the issue in the best way for his mind. Regarding the metastasis, the lymph node metastasis, I'll be very quickly, also because Giovanni told you before everything about the recommendation of international guidelines. And also in this case, I have a couple of video, very short. Fortunately for you, he spoiled my video because he showed the same video that I presented. And for this reason, coming back to Italy, he will be fired immediately, obviously. And okay, very briefly, we have this metastasis at a long distance from the surgery. You see that was also diagnosed with a CT PET that demonstrated the presence of a node metastasis in the anterior part of the wall. Thyroglobulin and antibodies were higher than normal during the follow-up, so we decided to treat this patient. We only for the malignancies prefer to use CUS, contrast enhancing ultrasound imaging, because it's able to well demonstrate the vascularity or the absence of vascularity into the node. In this case, you see that the metastasis is very rich vascularized. So this is the study immediately before the treatment. The nodule was quite superficial and is below the platysma, and is included into the layers of the superficial fascia, and while the deep fascia was below this area and include the big vessel and the left bed of the thyroid that was removed years before during surgery. We respect very easily the dangerous triangle because quite far. So we decide to treat this, not because the patient completely refused to be reoperated, even if the nodule was quite superficial, so it was not a very unsafe or difficult surgery, but absolutely he declined to be operated. So we start with the superficial hydrodissection, always using the anesthetic in this case, isolating the nodule from the muscle and from the skin, and also we insulate it from the deeper part, okay, because below we have the dangerous triangle, we have the nerve, we have the vessel, and so on. Then we proceed to insert the antenna. In this case, we proceed with a netting gauge by Canyon company with the protocol that you can read here. You see that the area of necrosis quite round shape. In this case, is very precise and is immediate. When you turn around, when you push on the foot pedal switch, immediately you see the necrosis that is effective. You will stay the time that is indicated by the protocol, by the algorithm, and you are sure that you have reached the full necrosis of the area. Then when we have reached this target, we move back in order to complete the other side, half side of the moon, in this case. And as you can see, with a single, just one withdrawal of the antenna, we fully necrotize everything into the lymph node. Then we will check after the procedure with the contrast enhanced imaging, and you will see that in the area of the treatment, we have a black hole. That means no vascularity, no residual vascularity. That means that we were effective from the oncological point of view. These images regard the follow-up at 6 months with the drop-off of the thyroglobulin and thyroglobulin antibodies, and at 9 months follow-up, the lymph node was no more clearly visible, and we also checked it with the contrast enhancing imaging, and you can see here the image before and the image after, where there is no enhancing imaging. So the treatment was successful, and you see that thyroglobulin became not dosable, and the antibodies became also very, very low. This is very important. You can start tomorrow with benign nodule, but don't think never to start with the malignancy. You must be very skilled to do this. Thanks to the technology, we can also go ahead to treat lymph node metastases and local recurrences, even if they are very small. We have the thinnest antenna in the world, the 19 gauge, that is suitable for the best candidates in this case, that are the metastatic lymph node and recurrences. You see here lymph node in the lateral aspect of the neck. This was a patient who was previously operated 4 times and expressly refused any kind of surgery. So we start to understand if it was suitable, very good candidate for the treatment. You see that the protocol is always the same. We start with the superficial hydrodissection, and we complete with the deep hydrodissection in order to let the nodule will float into the liquid. Then with a single insertion of the antenna, we will produce the necrosis that is clearly visible in this slide. This is the follow-up protocol, and you will see in this area will be black hole, so no vascularity. The treatment was completely successful. And I conclude this my presentation for a general invitation to join us in the Save Your Thyroid community. If you have a picture, a screenshot of the QR code, you can link to the site and you can participate to the community. and also to have a look to the master classes and the courses that we plan all over the year and in all the parts of the world. I think and I hope that next year you will appreciate the possibility to start also in Morocco. And I don't know if it means shukran, because thank you.